Right. Hopefully you can now see the slideshow. Great. So welcome. My name is Harry McMillan. I'm one of the directors of Momenta, joined by Dr. Holmes to run through this referral support session for the NHS Type 2 Diabetes Path to Remission Programme. And I say that with a straight face after a couple of drinks. Now, I'm also joined in the background by John Scott, the manager for the contract, and Johnny Bruce, who's the engagement lead, many of you might know them already. So we've got a fairly full session, so I suggest we just dive straight in. I will be covering the first and last part of the agenda, and Patrick will be doing a much better job on the medication adjustments in the middle. So I'll also theoretically be controlling it, so if it goes wrong, it's all my fault, not Patrick's. So, as we said, welcome first off. Secondly, it's being recorded, and thirdly, if you are not presenting, if you could please go on mute, that would be very helpful, especially if answering phone calls. Right, so a little bit of background and benefits of the program, because most of you most of your practices have not made referrals, so I'm assuming that this is going to be fairly new to all of you, at least in the detail, even if not in principle. So in terms of the research that the program is based on, there's a couple of studies called Direct and Droplet. Many of you will probably be familiar with these, particularly Direct, because that was done at the University of Newcastle and University of Glasgow. And they're the ones that basically showed that remission of type 2 diabetes was possible in a primary care setting at scale and through lifestyle intervention as opposed to surgery or other means. In Direct, at 12 months, the intervention group, a quarter of them had lost over 15 kilos, which was a staggering amount of weight from a lifestyle intervention at that level. And just under half had achieved remission by 24 months, i.e. 2 years. That had dropped a bit, as you'd expect, but was still over a third. There were fewer adverse events in the control group than in the intervention group. Remission was very closely linked to weight loss, as many of you will know, but it was almost a direct straight line. And remission, for the purposes of this study, or this program, is defined as having an HbA1c of less than 48 millimoles per mole for longer than 6 months, or 6 months or more, on no medications. As you'll see when we get to the medication adjustment protocol, that means that some people who start this won't technically achieve remission, but they'll still get many of the benefits of the program from the significant weight loss. And the final thing I should have said before we started, sorry, is if you've got questions, please, you're welcome to say them at the end if you want, but please also just put them in the chat and we'll try and cover them as we go. So patients have significant benefits from the program, other than the weight loss itself, the possibility of remission of their type 2 diabetes. There's an average of a 50% reduction in diabetes-related medications and also associated blood pressure medications. There's a significant impact on people's comorbidities, improvements in quality of life, healthy living, and above all, the entire 12-month program, so that includes all the coach support and all of the total diet replacement products, the meal replacements, are free of charge or paid for by NHS England. And there are some case studies there if you want to bring some of this to life. There are some videos and also text-based case studies, but it can just bring some of these theoretical benefits and make them much more real for either yourself or your patients. So benefits for practices are, obviously, it's a free service in the sense that NHS England has commissioned it, working with the ICB. Eligible referrals can qualify for the weight management and service fee. And then, probably more importantly than that, there's anecdotal but not quantifiable indications of significant benefits around reduced demand on practice from successful participants. So not only do they lose weight, but that obviously has an impact on their comorbidities. And also from a group-based model, there's a significant amount of peer support, all of which is helpful from a practice use of practice point of view. Just in terms of background, this was piloted as the NHS low-calorie diet. That's how we started in North East North Cumbria, and in June this year it changed to its new snappy title. The emerging results from the pilot sites and now the framework are looking in line with direct. As a provider, we've been your provider since the service started in North East North Cumbria. You've had a couple of other remission services as well, but this is the NHS England commissioned one, and so is the one that's now delivered across all of North East North Cumbria with the exception of Newcastle, where actually our programme was delivered but separately commissioned, just to be slightly confusing. We're now working in 7 of the 20 ICBs where it's been commissioned, and you'll let us know whether you'd like us to continue doing that when it's recommissioned in North East North Cumbria from the 1st of February next year, because that's currently being determined. But either way, the service is going to continue. And so the early outcomes are that there's an 11 to 13% weight loss at 3 months, and that's maintained into phase 3. So that's very in line with direct and in line with the other ICB areas. There's very positive uptake, and it appears to help address health inequalities because we have disproportionate referrals from areas of relative deprivation and from ethnic groups. So the purpose of this session is, or the catalyst for it, is that there's a little bit of a ramp up in referrals which is required across North East North Cumbria. Currently, it was launched with a phased rollout, and that continued and has only been expanded relatively recently. I think someone might have come off mute. If you could possibly go back on mute, that would be very helpful. Thank you very much. So far, only 200 of the 500 places that NHS England have paid for have been used, and a few months left of referrals under this contract. So now that the service is being rolled out across other parts of North East North Cumbria, it would be really helpful if you'd be able to start referring as rapidly as possible after this to make the most use of this funded resource. Obviously, we're here to support you do that as best as possible, starting with this session, but continuing with support from Johnny and John as well. So what's the programme actually look like? As we said, it follows the principles of direct. It's delivered by trained coaches. There are 3 phases. The first 3 months or 12 weeks are 800 to 900 calories a day. So that's all from T2DR products, which are total diet replacement products. So soups, shakes, bars, and other meal replacements. After that first 3 months, there's then a 6-week period where we help participants reintroduce real food to their diet. So that's one main meal every 2 weeks, and it's a very structured approach, and there's lots of support provided around that. And then for the final 7.5 months, we support participants to help build healthy eating and activity back into their daily lives, and increase those to the kind of recommended levels, or in some cases more from an active view, which is really helpful. Weight back on, then they are eligible for what's known as a rescue package, which is a month worth of total diet replacement products to help them kind of restart that. They're only eligible for that once, but it's an offer that's there. The format at the moment for everyone who's referred up until the end of January is in-person groups. A product supplier for our TDR products called Exante, come on to why in a minute. And that the service will continue from February next year. It's just the format will change at that point, whether we're providing it or not, because it will be provided under a new framework. But fundamentally, it will be the same service, just delivered slightly differently. These are the eligibility criteria. We won't go through them in detail now because you'll receive all of this afterwards. I'm just going to highlight a few which people sometimes miss out because it's a slightly different, slightly more restrictive than some other programs. The first is there's an upper age limit of 65. So it's for people diagnosed relatively recently with type 2 diabetes, so within the last 6 years. The HbA1c limits, there's an upper limit for everyone of 87. And if people are on diabetes medication, the lower limit is 43 or above. If they're not on diabetes medication, then it's 48 or above, and that's within the last 12 months. On the exclusion side, the insulin is an exclusion criteria, and fundamentally, your judgment as healthcare professionals is paramount. So if you are not confident that it's possible to refer people safely and they're either not able to follow your medication adjustments or it's not practical to monitor them, then you've just got conditions that you're not 100% certain about, then you should not refer them. It's down to your judgment as well as these other factors. This is just a brief overview of the different sessions and the kind of core message or content in each of those sessions indicated by the titles. There's a lot more than that behind it. Each session's an hour long. So resources, as you can see, that we provide participants with, it's just a quick snapshot. And we use Exante to provide the products, and that's because they've got the widest range, both of flavors and textures that we've come across. The participants, and that was considered very important from the research, because when there's a limited range, then people are more likely to struggle with it. Participants order directly. We provide them with voucher codes. We can support anyone who is struggling, and they get free next day delivery to their home or office. There's an example link there if you want to follow it at a later point. And obviously, as we mentioned before, all of these TDR products cost. It's just a snapshot of some of the resources, so you can see that we're trying to look after your patients. So we're providing them with resources that are well laid out, they're interactive, there's lots of space to write in them, to make notes and all of that. But there's also an awful lot of information which they don't go through all of it in the sessions, but it's for them to take away as well as trackers, logbooks, recipe books, access to an app around physical activity, and say pedometer as well. So finally, you'll be glad to hear from my point of view, before Patrick moves on to talk about medication adjustments, I'm going to just cover off the roles and responsibilities and referral pathways. So this covers the roles and responsibilities respectively for yourselves and for us. Unfortunately, because we need referrals to deliver the program, the work starts with you. So there's a few ways to identify eligible participants we'll come on to in a minute, but fundamentally we need to receive the referral and medication adjustment form from yourselves. We provide some support to help you with that. Once we've received a complete form for an eligible individual, we confirm their eligibility in a registration call, and then have an individual assessment. And apologies, that's ignore the pathway piece. That was a incorrect slide there. I'll circulate the updated one with the correct version. Basically, individual assessment, we go through the program in more detail, make sure that they're happy to proceed and they understand all of the relevant details. After we've started that process, then the only additional work for you in the practice is to do a repeat HbA1c at 6 and 12 months. And then also, if your patients exceed some of the monitoring thresholds, which I'll come on to in a second, they may require a medication review. Also will on discharge or completion. So over the course of the 3 phases, apart from delivering the program, which has the 21 odd sessions, which are about an hour long with an extra 15 minutes for the monitoring, we also monitor weight and blood glucose for all participants, and we provide everyone with blood glucose meter and a number of strips they need for the program and that side of things. And we also monitor blood pressure for those on blood pressure medications at referral, as well as various other aspects. We have a medical director who is a GP specializing in diabetes, and if your patients exceed the thresholds that NHS England have set out for blood pressure, blood glucose, or below BMI thresholds, then we'll examine those, she'll be involved, and we'll communicate with you as required. Her involvement as medical director is to make sure we don't send you unnecessary communications, but only communicate as we are required to by the contract, and also we make sure that you're aware of anything that needs more rapid attention. And these thresholds are clearly set out in the specification. We can give you more information if you wish. We'll also send you clear actions around coding and any other communication with patients. If you can do referrals based on a search as opposed to just ad hoc, that's helpful because it means we're more likely to be able to set up a group in your area, and so that will reduce patient travel and waiting times. It's not necessary, but it's just helpful. So in terms of identifying interested patients, there are basically three choices. The first is one you'll be familiar with from programs like the DPP, so it's a search and invitation. So screening first and then invitation. We have both the that you can send out with a text if you like, and also the landing page, which is an electronic version of the same thing basically, but on a website. Then there's the opportunistic approach. So for example, on diagnosis, at annual reviews, or if a patient requested, if they've heard about it. And finally, there's what we refer to as a bespoke approach. So some practices are, or even PCNs, are keen to run an event for their patients, so that rather than just send a flyer or a landing page by a text, they'll invite them to an event. At which point, we're very happy to support you with that, and we've got lots of experience of things that work well or less well through the event and provide sample products and that sort of thing, and talk about the program in more detail. But I would say that's only for those who are really interested in this, because there's a fair amount more work. The rewards are helpful, but there's definitely additional work. So the main ways that people are referred to this program is either through a search and invitation or through referrals. Given the time scale left in this contract and the number of people that we'd like to take, get onto the program to take advantage of the funding, we'd recommend the search and invitation because you can get a bit better volume that way. It's also the most efficient way. The opportunistic way is probably where it's most relevant to your patients. Here, the example of the patient flyer, patient information leaflet. As a practice poster, these are all downloadable and printable. Send you the actual the document as well, and that's the example of a landing page, or the example, the URL for the landing page. Right, at this point, I'm going to hand over to Patrick to talk you through the medications adjustments and deprescribing and potential retitration afterwards, and then I'll pick back up on the searches and referral forms at the end. Okay, thank you very much. You, Patrick.
Thanks, Harry. So for those of you who don't know who the hell I am, I'm the primary care diabetes network lead for the North East North Cumbria. So I'm a GP down in the Darlington area. So yes, I'm going to just talk a little bit about deprescribing. So of course we're more used to prescribing than deprescribing, but the evidence really for this comes from the direct study itself. So in the direct study, which is slightly different from what's been done, will be done in this NHS programme. The NHS programme is a bit more conservative in terms of what we did, but in the direct study, they stopped their blood pressure pills, unless it was very high, but they stopped their blood pressure pills and stopped all their glucose lowering agents. So as I say, it's a bit more conservative here, but that's why you can see relatively high levels of glucose if you look at the image in the top left-hand corner, and they drop relatively quickly. Blood pressure, you certainly see that drop in blood pressure. You see, again, you can see dropping by about, 20 millimeters of mercury thereabouts. So these so it's important when if you bear in mind the blood pressure, when people on these meal replacements, they're also not only low in calorie, but they'll be low in sodium as well. So that's why you get that immediate drop. And of course, weight is quite strongly associated with blood pressure. So if you're losing weight significantly, as we've seen, at the end of the program, you're looking at about 10 to 15 kilogram weight loss. And my understanding is that's the sort of that magnitude of weight loss, that 15 kilogram weight loss is still, for the completers in this program, is equivalent. So of the data I've seen on this. But I suppose the important thing, the prescribing, even though they're part of this program, the prescribing still sits in primary care. It's still our responsibility in terms of making these adjustments. We go on to the next slide. So what I'll go through with this, really, we've got some glucose lowering agents, and then there's a bit about blood pressure, and then there's a bit about other drugs, which weight is important. So in terms of first of all, glucose lowering agent, you can see on this, really, there's a bit of a flow chart, certainly for our patients. So even if they're not on any medication, we're meant to write in the referral and medication adjustment form right at the get-go about that section should be filled in. If they're on just a couple of agents, 1 or 2 agents, then you would stop those at the beginning of the remission program. If they're on 3 or more agents, you would leave them on their base therapy, which would typically be metformin, unless they're intolerant of metformin, and then it would be probably a DPP-4 inhibitor or a GLP-1 receptor agonist, and we'll come on to that very soon. And there needs to be clear instructions, really, for the patient so they know what they're doing. And as I say, it's important that the program is also aware of these treatments in the referral. Again, just a reminder that if they're on insulin, that's an exclusion. So for this program, because obviously there is some people out there who are labeled as type 2 diabetes, have type 1 diabetes. They're exclusively on insulin, so we don't want to. You can't reverse type 1 diabetes through weight loss, of course. So and if we just go into the specific issues with some of the medications that we can see. There we go. So really for SUs, these metiglinides, so they're not very commonly prescribed, sometimes known as postprandial regulators. The main issue would be hypoglycemia. If people are losing weight, they're at significant risk of hypoglycemia, because obviously their insulin resistance will improve with that weight loss. And again, SGLT2 inhibitors, this is not only a low carbohydrate, low calorie diet, but it's also very low carbohydrate. So there is this theoretical risk of increasing the risk of ketosis, which so we would look for those patients to be stopped from that. GLP-1 agonists, of course, are a rare beast these days. So I think generally they are safe to continue, but I think we should be considering stopping those for economic reasons as well. And as I said, this is a fully supported program, so it's a good time if you're looking to stop GLP-1, actually having someone on a program like this. There will be some flags within the program. So clearly, if their blood glucose is rising quite significantly, or we're seeing rises in the HbA1c, then that will be flagged up. And really, at that stage, some adjustment in medication would be expected by the primary care team, the GP or nurses or pharmacists for that matter, who are managing their diabetes. And again, just a reminder, there are certain no-nos on this. Not only insulin is excluded from the program, but also the agents which cause hypoglycemia and the SGLT2 inhibitors for the reasons I've discussed. Next slide. Blood pressure. So as we've said, the blood pressure is also something we need to be mindful of. So when you're making a referral, if the blood pressure is control, there's no need to, well, if their blood pressure is above target, rather, there's no need specifically to change unless there's a clinical reason to do so. The expectation is that they're going to be losing weight. And again, just it was a bit of a call out about the different ways which Harry mentioned in terms of referring. I think doing a search, because these programs, you have to have a certain number of people. The search option is really good, because then if you do, for example, refer 30 or 40 appropriate people or people who want to be referred, you're likely to have a very local session provided, which obviously makes it more inclusive for people who don't have transport. Whereas if you're only referring 1 or 2, potentially they're going to be waiting a period of time, which might cause some of these issues with the medication changes, and also may exclude some people if they're only offered a program a bit further afield. Going back to the blood pressure, so yeah, if the blood pressure's above target and there's no immediate clinical concern, then you would just record all that information and refer them on. Again, if the blood pressure is under control, which hopefully most of your patients will be, then the recommendation is that we look to stop whatever the most appropriate agent is, and we'll come on to that in the next slide. But and again, that's for instructions, so the patient knows to do that at the beginning of the treatment, the diet, total diet replacement phase of the program. So if we just move on to the next slide. Yeah, so I suppose the important thing is, and I'm sure I'm speaking to lots of people who are aware of this, sometimes these blood pressure treatments, we get 2 for 1. Not only does it lower their blood pressure, but there may be other good clinical reasons for them to be on it. Obviously, when we're talking about diabetes, people may have evidence of a nephropathy, so we're treating that complication with an ACE inhibitor or an ARB. They may have angina, where either a beta blocker or diltiazem is being used for both blood pressure. It's heart failure. Obviously, there may be a whole spectrum of treatments. Judgment needs to be made whether some of these patients would be good candidates. I think it has to be said. Obviously, doxazothine for benign prostatic hyperplasia, and again, beta blockers or ARBs, again for migraine. So if there is another reason for them to be on that, obviously we would look for that to be continued if at all possible. So you would be stopping the agents which you can do, assuming there's no particular strong reason for them to be on these agents other than hypertension. Then again, you can see the list. It's basically an inverse list of what you would add in if you're following NICE guidance for in the context of type 2 diabetes, where ACE inhibitors or ARBs are your first line agent. So it's essentially prescribing as per NICE, but in a reverse order, and it's obviously de-prescribing. Next slide. So again, some checks within the program, again, following NICE guidance, but if there is blood pressures going up, then obviously there would be some recommendation coming from the team, or indeed, I would encourage your patients probably to keep an eye on their blood pressure. I certainly do. And if they're finding that their blood pressure is going high, then we obviously need to review them in a timely fashion as per NICE guidance. So if their blood pressure is going too low and they're still on blood pressure agents, so again, this needs to be adjusted by the individual. Here's some numbers, but obviously some patients may be becoming hypotensive and symptomatically so. Of course, one should remind people that is a small possibility, particularly in terms of postural hypotension. I probably should have mentioned that earlier, to make sure that they're drinking plenty of fluid during particularly the first few weeks of the total diet restriction. But yeah, if their blood pressures are falling, certainly with a systolic below 90, I think we should be stepping down their treatment, and obviously considering if they've got some significant comorbidities such as heart failure, we may need to be even seeking specialist advice. But again, the responsibility, as always, lands with us in primary care. Next slide. So, of course, there are some drugs.
Sorry, Patrick.
Yep.
Can I just pause you for a second? There seem to be some people who are having difficulty with the slides. John, can you see the slides moving on or not? And can you hear Patrick?
Yeah, it's all good, my end.
Okay, so I suspect if you are having difficulty, anyone, it might be at your end, because I can see them move, John can see them move, and Patrick can. So maybe if you could log it off and log back in again, that would be helpful. And there are a few questions also coming in about referring and stuff, which we'll come to in a second after Patrick's finished the medication adjustment section.
Yeah, and
okay,
I'm sure you're more than willing to share these slides. I think for those people who are struggling to keep up.
For sure, yeah.
My experience of working in primary care in the NHS, the internet connections we're given are pretty rubbish. So these people will be at work, a lot of them. So jumping from one slide to another, unfortunately, the internet doesn't keep up. So so this section, just a reminder that there are other medications which we might need to adjust based on if people are losing significant amounts of weight, because we'll be calculating what doses they require on the I forget the full name, but anyway, the renal calculator, Cockcroft creatinine criteria, whatever it is, calculation rather. So those renal calculations we use, I suppose DOACs is probably the most common ones we would use in primary care, but there are other drugs. So we just need to bear in mind when we're making those referrals that we are looking at identifying those patients and making sure we're keeping an eye on them during this program. So there's a list which is going to come on the next screen, which, as I said, some of these patients may, if it can't be done safely, and you'll look at some of these and they, for example, cyclosporin, that might be something which makes it very difficult for us to be managing in primary care. DOACs, we do have perhaps more experience of people who are changing weight or renal function and appropriately adjusting those treatments. This isn't a complete list, and it's not exhaustive, but certainly this includes the most common ones which are on there. I would personally, I'd be quite confident at managing the DOACs and digoxin and warfarin, but perhaps less confident with some of the others. And again, that might mean these patients, not all patients, are going to be practically good candidates for a remission program, but I would say they're only going to be a very small number of people, particularly bear in mind it's 18 to 65 is the cohort of patients with type 2 diabetes we're looking at. I think that's briefly my section. Yes.
That is indeed. Thank you, Patrick. Much appreciated. And as we said, we'll circulate a copy of the slides and the recording at the end of the session or shortly afterwards. So apologies for any quality issues in the meantime. We had one question that came in about when do we start deprescribing after you've referred, and actually that's why the referral and medication adjustment form are combined, because there's a variable time depending on how many people, whether there's a program coming up that your patient can make or whether they prefer to wait. It's important to fill out the medication adjustment form at the same time as sending the referral, giving a copy to the patient, but making it clear to them that they should only make those changes on the first day that they start total diet replacement products. Now, we will reinforce that message pretty much every contact we have until then. And we will also communicate to you or write to you via the practice admin email address to let you know when your patients are starting the total diet replacement products. So you will know when they've made their medication changes. If your patients tell us that they can't remember, if they remember more or less what they were told to do, we can provide them with the copy you've sent us. If they can't actually remember, or they're not sure if they've changed medication since or anything else, then we'll have to send them back to you just either to check and confirm that, or to update the medication adjustment form. So we do, for your kind of comfort, we check that both on during the individual assessment and looking onto the program. So, and also in their first session, their coach will go through that as well. So there's quite a few checks built in, but it's important to make the medication adjustments changes on the same form at the beginning. So there's another question earlier about searches and referrals. That's what we'll come on to next. And all this information is also on the referrer support webpage, which we'll send you a link to in these slides. So steps for making a successful referral. We've talked about identifying and inviting eligible patients. So those are the three options, or three, both the search, screen and invitation, or the opportunistic, or the bespoke event. There's just a question come in a bit. Are the referral and medication forms both on System 1? We need to access them from the website. You can access them from the website, but they are on System 1 in the CDRC directory. And again, there's directions to that on the referrer web form. They are, some might still be, because we don't have direct access to change that, some might still be referencing the NHS low-calorie diet, but the form is the same. And for EMIS, the forms are on the site, which will circulate and you can download. Hopefully that makes sense. If not, please get in touch with us afterwards. So after identifying eligible patients, then you'll need to make a referral appointment. Now, our experience across the board, well, not our experience because you're the ones making the appointment, but what we've been told is generally this, you should allow about 15 minutes. You can have longer if you want, but 15 minutes should suffice for most patients to review their record, talk to them about the program, the referral, the medication changes, and then also to fill out the form and send it to us or send it to your admin to forward to us. Importantly, providing them with a copy and then sending it to that email address there. Completed or the eligible, particularly if it's not completed, we'll unfortunately have to send it back to you to ask. We'll not just send it back and say, do not pass go. We'll be as helpful as possible in pointing out what hasn't been completed and what please you should do. But it does all add time to the process, and your patients won't necessarily be aware of that, and so they'll be expecting us to get in touch with them a bit sooner. So the sooner, the more complete you can send them in the first place, the better. And if there is anything to update, then the faster you can do that, the sooner we can get in contact with them to let them know. So this Delight is what the referral and medication adjustment form looks like, more or less, depending slight variations between EMIS and System 1, but fundamentally it is this. Now it looks long, but don't be too concerned because first there's some reference information you'll see on the first page up here. See, it's still referred to as a low-calorie diet program referral because we didn't want to change all of the information and get everyone to update all of their systems for a few months of referrals, which seemed like a lot of work. So to make life easier, we've left it as it was until the end of this contract. You've got the eligibility criteria up front. You've then got some auto-populating patient information, background, etc. There is a set of tick boxes on EMIS or just auto-populated sections on System 1. So if you're lucky, if you're on System 1, about responding to whether your patients are on specific medications at referral. And to help you fill that in, the acutes and repeats get pulled through into this section here. So again, depending on how many medications your patient is on, those get pulled through. There's a declaration section at the end, and then the last two pages, so at the end of the form, are the medication adjustment section of the form. There's some instructions to referrer and to the patient on the first page, and then the final page has medications they might be on, the instruction as to whether they should, the exact medication name to make it easier for the patient to match the instructions to the actual packet. what they should do. So should they reduce it, stop it, or in some cases increase it. But I can't impact how the slides are processing at your end. There's another comment. It's down to the local internet connections, because we've confirmed various locations. So I'm very sorry about that. In terms of a few tips for searches and referral forms, after the search, it will obviously come back with a long list. You will need to do a manual screen of those to confirm eligibility, because there are some things that can't be easily searched for, or searches don't work very well with historic coding challenges. So just check against the key criteria. If you get a very long list, which is unlikely at a practice level, but if you did it at PCN level, might be more likely, then you can batch them and triage them, if you want. But otherwise, most of the time, this is a reasonably swift process within a practice, and you can then invite them. Questions in the chat. Do you get a notification as to when the patient starts the program? Yes, you do. We'll let you know when they start the program, and we'll also let you know, at any point when they stop the program, if that's before, well, whether it's on completion or they drop out beforehand. And there is a search available on System 1. It's in the CDRC directory. In terms of the referral medication adjustment form, obviously confirming the eligibility criteria before proceeding, otherwise you're going to be taking up your time and theirs unnecessarily. Ensuring, as we've said a few times, that you give the patient a copy of it. We're not saying it a few times, we're just saying it a few times because sometimes that doesn't happen, so it's worth reinforcing rather than just boring you. And as Patrick said, if there are no medications to be adjusted or that need adjusting, if you could just complete the tick boxes at the top of the medication adjustment form that says that, then that means that we'll know it's not an incomplete referral, it's complete, but there's nothing to change if the form is not complete beforehand. Right, you'll be delighted to know I'm not going to go through this in detail, but it is a one-page flowchart for the service, and basically takes you through in the blue boxes, the kind of default approach for primary care. In the light blue are different options, so that's the ad hoc referral approach as opposed to the default search and screen and text approach. The referral itself and sending us the form, and then the repeat HbA1c which needs to be done. There are some optional points, so some people like to have a practice event, as I said, others like to send repeat texts. If there's missing information, it'll need to be filled out. And there might be medication reviews over the course of the program that exceed their thresholds. We will chase you if anything's missing. We'll then deliver the program to your patients, and we'll notify you any threshold breach side effects, and we will let you know if they decline or they drop out as well. A couple of SNOMED codes on here that we can't tell you about because we don't know if you invited someone or they've declined. But after that point, all of the coding writes you about with an action for coding at the top. Same page, you have access to the links for. We will operate, when I say we, I really mean Johnny will operate a number of drop-in sessions on a weekly basis, and also make, he's got a handy link at the bottom of his email to make his, so you can book in a slot with Johnny if you've got any questions or you want to go through any of the detail. So we can support additionally after this session with that. We have a patient landing page and the leaflet, which we told you about before, which we highlighted beforehand. And the referral resource page is here as well, a link to that. The email to send us referrals, telephone number if you want. Most people don't, but some do. So next steps are really pretty simple. Obviously, any questions, discussion here, either in a chat or verbally. We'll send you follow-up of the slides, the full NHS England guidance, and this is all on the website. please feel free to update any of your colleagues about this service, and they can book in a session with Johnny. If you have any local events, we're very happy to attend those as well. For a short version of this, don't worry, we can do 5 or 10 minute versions if that's helpful without going into some more detail. We very much look forward to your referrals. And here it's just, you'll get in the back of this slides when we send it to you, a set of contact details all on one page. Also Lynn's contacts as from the ICB, and that's Johnny and John, who I mentioned beforehand. So you'll be delighted to know that is it from me, but very happy to answer any questions. I'll stop sharing, or you might well have more relevant questions for Patrick than me on the prescribing side, so please ask them to him as well. John, just to say, there's a email in the chat to send the slides to, as well as people who've been registered for this call. What size of referral will you consider making an individual? So we can run, it depends what the group is. Normally, we would prefer, yes, I thought that's what you meant. I was just trying to figure out what size of, but anyway, no. So normally, we would run a group for 10, or maximum we'd start off with is 15. If you have either a remote area, or you have a particular group in your practice you want to start, or even if you have a venue you want us to use or anything like that, then we can accommodate smaller groups. We'd be very reluctant to go below 6, and fairly reluctant to go below 8, because it's a 12-month program, so you're always going to get some dropout due to lifestyle, sorry, not lifestyle, life events and things over that period. And part of the benefit of running a group session is the peer support and learning. It's very helpful if we could get 8 or more. The question is, could we be more specific about the time commitment? So yes, it's not an hour per week. Sorry, it is. It's not always in daytime. So in fact, our most common program time is in the evening, mostly weekdays, although we do offer weekend ones, but they're not as popular. The programs are an hour and a quarter long, 15 minutes for the measurements, and that again is shorter, obviously, if there's fewer people. And there are 21 sessions over the course of the year. So they start off, the first 4 are weekly, and after that they go fortnightly, and then they go monthly. So there's a gradually decreasing frequency of session, and most people don't seem to find that too onerous, because they've only got to go for an hour a week for the first 4 weeks. John, there's a few more for the slides in there. It's normal time to first appointment from referral. So that does vary a bit. Some people literally will start within a couple of weeks of referral. Probably the average is about between 3 and 5 weeks, depending on location. If people don't find that the next program coming up suits them and they want to delay, then it can be longer than that. As we said, we will always let you know when people start the program. So as soon as they actually start the program and start the total direct replacement products, we'll write to you and let you know. So you'll have an idea. Well, you'll know exactly when they start for any follow-up. That answers the question. If not, please prompt me with anything else. When referral is able to start and when does the contract end? So I guess the good news for you is that the service will continue in Northeast North Cumbria for at least another 2.5 years, and probably longer. Answer is that for this contract, so the one where you've currently got a lot of extra capacity that's unused, for historic reasons of phasing it out across the area slowly, running it out slowly. Referrals can be made up until the 31st of January. So for another sort of 4.5 months, effectively.
But there's going to be, as you say, Harry, there's a program after that. So yeah. So but it might tweak in terms of how the referral is. But yeah, just they basically get cracking with the referrals, I think, is the summary.
That is indeed the summary. And we will, even if you make a referral on the 31st of January, they'll still be able to start a program up until the end of March. So they don't have to, don't think, oh, there's no point in doing it after the end of November because they won't start over Christmas, and then they won't start in January. The more the merrier, the sooner the better. And we've got lots of coaches, lots of coach capacity. We're actually training even this week, and we will start programs as swiftly as possible. Yes, Ardens. The referral forms are on Ardens, but I'm not sure if it's actually the North East North Cumbria referral forms that are on Ardens. You can find some Memento forms, referral forms on Ardens, but from what we understood, Ardens are quite specific locally in terms of places. So you might not be able to access them. If you can't, please let us know, and we can. We're happy to talk to whoever we need to talk to get the forms up on Ardens. We haven't come across that yet in North East North Cumbria. We only had the EMIS and System 1, and as we mentioned, System 1 is all on the CDRC directory, which I believe everyone uses. EMIS is available on the website, and if it needs to be uploaded centrally in your locality, please let us know, and we'll work with Lynn to get that addressed as soon as possible. Okay, and by the way, there's lots of people putting in their emails in the chat for the slides. If you registered for this session, then your email will already be in the system, so you'll already receive the slides. So if you registered, you don't need to type them in again. If you didn't, fill your boots, let us know. Okay. Patrick, anything else from you or any other questions?
No, I think I would, just from a practical basis, I think doing those searches, identifying your patients, and it's a good time to do it now, because of course it means you're capturing quite a lot of your QOF data as well, because of the various different checks that you're going to need to do to refer it. It's important in terms of the language that we, as we've seen with some of the numbers, although remission, if people do lose that 10 to 15 kilogram, they're 85% of people achieving that weight loss will achieve remission. So, and from the data I've seen, this program is delivering that sort of weight loss. So do expect that. But remember, over the fullness of time, a lot of people go back to having diabetes. So they've benefited from the weight loss. And of course, that would benefit beyond diabetes to a whole bunch of other conditions in terms of back pain and the sleep apnea and various things. But it's important, I suppose, just be careful in terms of the language, because, whilst hope, remission is about hope, and it's really important that we instill hope, we also need to make sure that when people, if people or when, I think the data for the 5-year data from direct study, I think it was 77% of the people who went into that study at the end of 5 years are not in remission, so their diabetes has come back. But it does tend to make their management of their diabetes better. So it's well worthwhile before you think that's a negative. But it's important that the language we use is that if people do develop diabetes, we emphasize the benefits in terms of the weight loss, benefits in terms of that normal glycemia for that period of time, and the benefits of reduced medication. So it's just because sometimes people can become completely demotivated if they feel their diabetes has come back. So just be mindful of that. But the best way to do is do those searches, get that cohort. Even better, if you've got a big practice. I know Egglescliffe is just down the road from me. They got a nice big practice. I'm sure if you've got a cohort of patients and you work with Memento, I'm sure they would be more than happy to support you, providing within in-house if that's an option. And for the larger practices, I suspect that is. Yeah. Good to see David. Yeah. So because that'd be great, actually developing that cohort of patients who've gone through this together. It can often be really helpful. And remember, there is activity is part of this. It's not just about losing weight. It's about that broader health in terms of their metabolic health, for sure.
Thanks, Patrick. That's really helpful. There's a couple of questions about the searches and referral forms and sessions of local groups. So if you want locality loading of the EMIS forms, then please let us know and we'll work with Lynn and NENC and your locality to do that. But we'll need to be told which ones, please. So ask us and we'll get onto it as soon as possible. Secondly, in terms of how do we find out locations of sessions if we don't have enough patients for local group to be established, most practices probably won't have a local group established. Our team's quite good at finding locations, but until we know where there's a cluster of people, that will determine where we find the location, where we determine the venue is. Because if you can imagine a map that starts off with a few people, if the bulk of the extra ones come over here, then we'll put a group on a venue here. If the bulk come over here, we'll find a venue over here. So it's not always possible to say we're going to start these programs in these places for sure, because we try and be as responsive as possible to where referrals are coming from. So that's a long way of saying we can't tell you exactly where they're going to be, but there's a good reason for it, and it's in the interest of your patients. The second thing is, if you have a venue you'd like us to use, and it's not the Ritz or somewhere that we can't afford, then please let us know and we'll do our very best to put on a venue there, because we're always happy to take local suggestions for venues as you make enough referrals. Not all from your practice, but from around about. Okay, Gateshead. Lynn will pick that up afterwards in terms of getting referral forms loaded on for Gateshead. But yes, we're pretty much on time as well, so I think we'll probably wrap it up there. I'll stay on for another couple of minutes, and John and Johnny will probably stay on for a wee bit longer. If you've got any more questions, feel free to drop them in. Otherwise, thank you very much for your time. And I'll stop the recording. And Patrick, thank you for your time as well.
So I have to jump off to another meeting as well. So anyway, thanks, Harry, and well done for organising.